In terms of the intrathoracic pressure, I found this quite interesting, mainly because I'm a pulmonologist, but the Mueller maneuver is where you create this amazing intrathoracic pressure. Once you close off your airway, you have to create a big intrathoracic pressure in order to take a breath in. And this causes increase in transmural gradients across the atria, ventricles, and aorta. It's thought that this changes ventricular function, causes changes in autonomic and hemodynamic instability, increases myocardial oxygen demand, which then increases your preload, your afterload, your atrial size, your wall stress, and decreases your stroke volume. And this is where we think that the impaired ventricular function comes from, and ventricular hypertrophy and remodeling. This is just a pictorial of the Mueller maneuver, and this is an open upper airway where you have normal pressure gradients across from the chest to the heart, and this is where you create a large negative pressure gradient trying to get air in through an obstructed airway, and you increase your preload and your afterload. This is actually important because many patients come in and they'll say to me, well, why can't I just be on oxygen to treat my sleep apnea? Well, the reason why you can't be on oxygen is because these negative pressures that are created during a closed airway really is the thrust as to why we have changes made in our vasculature and increase in cardiovascular risk. So now I'm going to switch gears a little bit and talk about the different cardiovascular problems that occur or risks of. And the main one is hypertension. We see 50% of OSA patients are hypertensive, and 30% of the hypertensive patients have sleep apnea. One study has shown that obstructive sleep apnea may predominantly raise systolic blood pressure, and there's a linear relationship with increasing AHI and increasing your blood pressure over time. There are a bunch of epidemiological and longitudinal studies out there showing that there is a link or increased risk of sleep disorder breathing with hypertension, and it is now accepted pretty much that sleep apnea is an independent risk factor for essential hypertension. They also talk in the literature about blood pressure dipping, and it is normal to have your blood pressure drop a little bit when you sleep. And what happens in sleep apnea patients is that you lose this sort of, they think it's a protective thing, but you lose this blood pressure dipping in sleep. And sleep apnea, nocturnal non-dipping patients is associated with sleep apnea, cerebral white matter disease with an increase in dementia and stroke, and then it's also been shown to be associated with all-cause mortality. CPAP therapy has been shown to decrease the mean arterial pressure by about 2 to 5 millimeters of mercury. There have been other studies showing decreases in blood pressure of anywhere from about 2 to about 12 millimeters of mercury. The response is in general better if patient has significant daytime sleepiness or more severe disease. CPAP has been shown to markedly reduce blood pressure and sympathetic production of norepinephrine in sleep. And most recently, this has just come out in 2011, that CPAP reduces arterial stiffness. However, I will say that these studies are usually smaller studies, they're cohort studies, and we need more sort of large randomized studies in order to really confirm everything that we're seeing so far in the research, in the literature. The progression of hypertension in sleep apnea patients we think is mediated by intermittent hypoxia, sympathetic activation, an increase in aldosterone in general through the renin-angiotensin-aldosterone system, and chemoreceptor stimulation. So now I'm going to switch to heart failure. Sleep disordered breathing is present in 75% of patients with symptomatic or decompensated heart failure. In general, of all heart failure patients, we see sleep disordered breathing in about 40 to 50% of patients. Interestingly, in heart failure patients with normal ejection fractions, we see a prevalence of about 69%, 40% being obstructive and about 29% being central sleep apnea in nature. In general, it occurs a bit more in men than in women, and risk is increased if you're an obese man, and unfortunately the obesity doesn't mean as much for women, but older age does. In general, heart failure patients with sleep disordered breathing tend to be older, have a higher BMI, a higher brain natriuretic peptide level, increased pulmonary capillary wedge pressure, and a lower PCO2. In general, I also, in the literature, sleep apnea, obstructive sleep apnea and central sleep apnea are both prevalent. It's not just one or the other. Obstructive sleep apnea usually does not manifest as sleepiness, so a lot of your CHF patients won't necessarily have the telltale daytime sleepiness that a non-heart failure patient would have. Central sleep apnea and Cheyne-Stokes respiration is an independent predictor of mortality. In general, the mechanisms behind why sleep-disordered breathing may contribute to heart failure is around hypertension, oxygen levels, and LVH. And in the literature, it says that hypertension is the most common risk factor for ventricular hypertrophy and failure. Nocturnal O2 desaturation predicts impaired ventricular relaxation during diastole, and left ventricular hypertrophy may be more linked to hypertension during sleep than during wakefulness. The progression of heart failure and sleep apnea, in terms of mechanism of how it happens, increased sympathetic outflow, cytokines, catecholamines, and endothelin contribute to the ventricular hypertrophy or remodeling. Negative intrathoracic pressures increase preload and afterload, as I discussed. Also, there's an increase in RV afterload from hypoxia and a risk of myocardial injury based on recurrent hypoxia. The progression of heart failure in central sleep apnea versus obstructive sleep apnea, the mechanism is a little bit different. There's a higher resting sympathetic drive, which is similar. There's pulmonary vascular congestion, increased chemoreflexes, prolonged circulation time, greater electrical instability, and increased cardiac filling pressures causing LV dysfunction. In general, it is now pretty much accepted in the literature that OSA is associated with these altered cardiac structure and function, and that they may be reversible with CPAP. There was a study showing after 3 months of CPAP, there's improved diastolic function, filling pressures, and function. There was also a study that showed improved LV, left ventricular ejection fraction. This was a study in about 24 patients, and the EF went from about 25% to 34%, and it also improved their quality of life. Also, CPAP decreases myocardial irritability and the risk for ventricular arrhythmias. The role of CPAP on central sleep apnea patients with heart failure is not that well understood. There was a study out of Canada in 2005 called the CAMPAP study that actually showed that it did not improve survival. However, when they did post hoc analysis of the study, they showed that actually there was improvement in survival if you got the apnea-hypopnea index less than 15 per hour. They've also looked at cardiac resynchronization with a pacemaker, and that actually is helpful with patients who have central sleep apnea or Cheyne-Stokes respirations. But in general, it's not clear if treatment of the obstructive sleep apnea or central sleep apnea will reduce the incidence of heart failure or improve survival yet, and there are a couple studies going on right now to address that. Now I'm going to switch over to talking about stroke. There's a very high prevalence seen with patients who have sleep-disordered breathing. There's about 40 to 70% chance of having sleep-disordered breathing in stroke patients. Unfortunately, this is a biased patient population because we're only looking at stroke survivors or patients who go on to rehab facilities. Sleep-disordered breathing recently has been seen as a risk factor for stroke, and stroke is now a risk factor for sleep-disordered breathing. And there was another study showing that severe sleep-disordered breathing is a risk factor for stroke in men. In terms of longitudinal studies, there are two good ones that are out there right now, and it actually does show that there's an increased risk of stroke and death in patients who have sleep apnea gone untreated over a 4-year period. There's another study that looked at patients over a 10-year period, and they saw that the patients over a 10-year period who already had a stroke, if you had obstructive sleep apnea, you are at a higher risk of death, but not with central sleep apnea. The mechanism behind the impairment that happens with sleep-disordered breathing and stroke, there's impaired endothelial function, there's accelerated atherogenesis, reductions in cerebral blood flow due to hypoxia, intermittent hypoxia, there's altered cerebral autoregulation, there's some prothrombotic and pro-inflammatory states that I've already talked about, and blood pressure fluctuations all are involved. In terms of CPAP, There's a study recently that came out showing that there was normalization of cerebral blood flow after about 4 to 6 weeks of CPAP therapy.